clinic. History of high-grade fever of 4 days duration associated with drowsiness and inability to walk, diagnosed elsewhere as viral encephalitis. He had complaints of sudden painless visual loss, followed by bilateral hearing loss of a week later. His UVAD's workup was entirely normal and his fundus appeared as in the picture. We were puzzled what to do, and we started the patient empirical or oral steroids, and OCT showed thickening of the inner retinal layers. After 6 weeks' time, the retinal layers showed thinning of the inner layers. We were all worrying what should be the exact etiology since the picture was bilateral. A week later, we had a 45-year-old lady present with defective vision, preceded by fever with multiple retinitis with hemorrhages, and again, all the complete uveitic workup was normal, and after starting steroids, the lesions healed as in the picture. Again, within a short span of 6 weeks, a 45-year-old lady presented with painless defective vision of 5 days duration, and the fundus showed a classical picture of neuroretinitis following empirical treatment with steroids. The neuroretinitis healed. Again, a 35-year-old gentleman present with bilateral defective vision of 10 days duration, neuroretinitis associated with hemorrhagic retinitis in the peripapillary area. The lesions healed following partially with treatment of oral steroids. So we did a battery of workup which all tested for negative for typhoid, malaria, leptospirosis, toxoplasma, syphilis, HIV. We sent the sample to France for testing of rickettsia and Bartonella, which all came as negative. We sent to the Defense Research Laboratory at Gwalior, where they tested for dengue and chikungunya, which all came to be negative. The lab people at Gwalior volunteered to test for this new emerging entity in India called West Nile virus, which came out to be positive. What they did was a LAMP assay, which in summary is a reverse transcription loop-mediated isothermal gene amplification assay that amplifies nucleic acid with high specificity, efficiency, and rapidity under isothermal conditions using a set of 6 specially designed primers that recognize 6 distinct sequences of the target. And they could identify the lineages as in picture lineage 1, which is so common in our Indian country. We also did an antigen as well as antibody capture ELISA, which correlated with the LAMP assay. So in a real-time RT-PCR and LAMP assays have a high sensitivity even with a low number of templates, and there are no concerns of cross-reactivity. Sequencing of RT-PCR amplified products and genotyping corroborated with RT-PCR results. Antigen capture ELISA and molecular techniques will identify even in early cases where the production of antibody may take time of 2 weeks duration. The molecular testing showed another advantage of its high specificity. West Nile virus was initially isolated by Smith-Byrne in West Nile district of Uganda. West Nile virus is positioned in the Japanese encephalitis serocomplex in the flavivirus genus. It is enzootic among passeriform birds and Culex mosquitoes. Outbreaks are caused by the tangential spillover of the mosquitoes in the equids. Humans are the dented host. The transmission mode could be transplacental, hematogenous, and organ transplantation. Incubation period vary from 3 to 14 days. The clinical categories could be asymptomatic or West Nile virus fever and West Nile virus meningoencephalitis. The symptoms vary from rashes to pharyngitis and high-grade fever. And neurological manifestations could be as decreased dependent reflex or West Nile virus polio, respiratory failure, tremors, and hepatitis. And the predictors of the poor outcome in West Nile virus could be diabetes and advanced age. Bilateral optic neuritis associated with West Nile virus meningoencephalitis has been reported as an indicator of poor outcome. Of note, we should differentiate the curvilinear streaks that are classically described in the literature compared to the linear streaks present in VKH, presumed ocular histoplasma, and idiopathic multifocal choroiditis. The pathogenesis could happen due to the hematogenous dissemination along the choriocapillaries to involve the choroid, cause a multifocal chorioretinitis. Occlusion of the ciliaretinal artery could cause a segmental wedge-shaped zones of RP changes. Vasculopathic effects could lead to retroretinal hemorrhages with white-centered hemorrhages. The different investigatory modes available for West Nile virus could be ELISA, which can be false positive in yellow fever, Japanese encephalitis virus, and St. Louis encephalitis virus. Lampasay is also being recommended, and the gold standard is a plaque reduction neutralization test. The differential diagnosis in multifocal choroiditis with vitritis and vasculitis could be a bird-shot choroiditis, atypical lymphoma, TB, sarcoid, or syphilis. There are no proven treatment of West Nile virus, only supportive. Antivirals like ribavirin are active only in vitro. The newer drugs like alpha B interferon and beta are under research mode. The treatment for anti-uveitis could be topical steroids, and posterior we give oral steroids, and when there is neovascularization we do PRP and Pass-plan a vitrectomy for non-clearing vitreous hemorrhage or tractional retinal detachment. For CNVM cases, we can plan anti-VEGF treatments. Evolution could be either self-limiting or with multiple recurrences and reactivation, or vision loss could happen because of ischemic maculopathy, optic atrophy and maculopathy, vitreous hemorrhage, tractional retinal detachment, CNVM and foveal chororetinal scar. The dilemmas which we encountered in these cases were, when the lesions were small, we thought probably we could be a cotton wool spot, and FFA and OCT settle the issue. And with retinitis, intraretinal hemorrhages in sparse vitreous cells closely mimic the CMV retinitis, but the workup was normal. The retinal lesions classically heal in all our cases without any pigmentation. This helped us in differentiating from toxoplasma, which is a classical scar, syphilis, which is also a classical RP scar, and tuberculosis, which is RP hyperpigmented scar. What was different in our case series was younger non-diabetic patients were affected compared to the diabetic patients predominantly involved in the western part of the world. Linear choroiditis was not seen on our group. All our patients had severe headache, facial edema and facial hyperpigmentation. Retinitis had sparse vitreous cells, and intraretinal hemorrhages, arteritis, phlebitis, macular scar and hyperemictis were also seen. Moving on to the second part of my presentation, a 12-year-old boy from Selenthal village presented with pain, redness and defective vision after bathing in a pond, and his height showed multiple granulomas in the anterior chamber. We also elicited history of similar problems in the children who were taking bath along with those children, and these children had a peculiar habit of taking bath in ponds multiple times in different part of a day. And they also had history of mucocutaneous ulcer preceding the onset that spontaneously disappeared. Complete uveitis workup was normal, and we went ahead with screening of those children and detected many more children in the camps. What was interesting was all these similar problems were classically absent in girls who rarely ventured into the ponds, and probably we thought this is peculiar to this geographical area. And these lesions recur when these treated children go back to our original ponds and not when they avoid. The treatment which we gave was initially started on topical steroids. When the lesions did not resolve, we went ahead with surgical excision of the granuloma, and the excision showed a classical scar as in the picture. Again, a 12-year-old boy from the same village present with multiple painless swelling in the lids and eye associated with perilimbal granuloma. And we did an excision and which showed zonal granulomatous inflammation with central necrotic cells and epithelioid cells. In the high MAC, we could detect a tegment of the parasite at the center. The aspirate showed necrotic neutrophils and eosinophils admixed with the intact cells. Few of the granuloma revealed Splendor-Hopley phenomenon with internal structures of the helminth. We went ahead and did a literature review to identify what could be the probable role of the trematode, and we found out that the trematodes belong to the subclass of Digenea, 40,000 species with intermediate host as Melanoides tuberculata. Since it was peculiar to this particular geographical area, we thought this software called Geographic Information System could help us to identify what could be the probable etiology. and we were able to predict the involved pawns using this software. And this was my thesis, in which we plotted all the patients and identified this using this geographical information software. These patients are coming from a particular area where one geographical zones blends with the other. What is the Splendor Hobley phenomenon? It is a central deposit of central granular acellular eosinophilic complex, which is made up of eosinophilic leukocytes, epithelioid cells, histiocytes, and lymphocytes. And these immune complex are composed of antigens, complement products, which could be derived from nematodes or trematode or fungal or bacteria. We went ahead to identify what is the exact etiology of a trematode. We did a DNA extraction from the granuloma and did a PCR. We collected the snails and collected the cercaria from those snails and identified them as melanoids tuberculata. We also did a PCR on the cercarial DNA, used a positive control with Fasciola gigantica and negative control with nucleus-free water. And using these assays, we identified the probable organism could be belonging to the genus of Procyrogum species, belonging to the family of Heterophagia of trematode. What is new in the treatment of presumed trematode-induced uveitis is cryotherapy, which was published in the Journal of AOIS, Indian Journal of Ophthalmology. They did cryotherapy for all these patients instead of surgical removal. Obviously, they have quoted the side effects as limbal stem cell deficiency, hypotony, and there was no molecular confirmation. Whenever we encounter any unusual presentation in uveitis, we probably have parasitic, malignancy, metabolism, degeneration in our differentials. The parasitic could be either a living parasite with mechanical damage, as in diffuse unilateral subacute neuroretinitis, where the treatment is albendazole steroids. This parasitic could present as dormant form in cysticercosis, where the surgical removal is recommended. Even the parasite could be a dead parasite with acute presentation of uveitis because of a ruptured cysticercosis. We treat with steroids. When the parasite is dead with a granuloma, as we have seen, probably could be a trematode where the steroids and surgical removal comes into play. Thank you.